matters. So for that reason, I like this simple notion: motion is lotion. I really like it, and this is something I hear a lot in the US, and I'm not sure if this is a common notion in Philippines or in the rest of the world. But I really do think this notion is sort of describes what OMPT does. I think OMPT facilitates the motion, which nourishes the whole physiological being and increases the human experience as well. So, if you put OMPT in that sort of a framework, all you do is just trying to improve the motion, because motion eventually, nourishes the human functions. And to that end, I really do believe it's very important that you always follow up with home exercise to complement OMPT. And probably this is the biggest change that I had since I finished the fellowship program. So before the fellowship program, my main focus was just providing OMPT, and a home exercise as more of a, I don't know, something on the side. Almost, I don't think I gave enough thought to the home exercise program. But now, I use OMPT so that I can fine tune what type of home exercise they can do at home. Because eventually, without an effective home exercise program, you really cannot expect any good carryover between sessions or long-term effect. So, having an exercise, so, for example, you apply certain techniques and they helped, and you really have to have home exercise to go with the technique. And this approach also, I think it works for many reasons. And one is that it certainly improves self-management, right? If the patient thinks whatever you did worked, for example, if you mobilize the hip and that helped the back pain, and if you teach them how to do home exercise and mobilize or stretch the hip in the same way that you mobilize, how encouraging that is for the patient. Now they have a tool that they can use at home so they can manage their condition by themselves. And also another benefit of this is to decrease the kinesiophobia. So through the application of OMPT, now you have shown the patient that the movement is beneficial and not something that you should be fearful of, right? And then you complement the home exercise program and let the patient do them at home. And I think really do help to reduce the kinesiophobia. So now this last one, I think is a little bit controversial. So I think I have a little bit of explaining to do. What I mean by be aware of your ego is not really, I'm not saying that you are all egoistic persons. That's not really what I meant here. Many of the OMPT practitioners are dedicated therapists. And I don't know, this is a misunderstanding, but I think more dedicated than therapists who's into more exercise-based therapies. For example, if something wrong with me, I usually choose the person who's sort of a manual OMPT or manual therapist because they're dedicated. Also, many of us go through certifications, continuing education, or fellowship programs. All these things, it matters. It makes you a better therapist. Makes you outstanding therapist. So now, one thing I think we have to be aware is really that us, we are so dedicated, maybe makes us quite unique and special. Okay, and that itself, I think it has a contextual factors, positive, possibly leads to the positive outcomes in self. Okay, but I think we need to realize that that I'm so special so is a double-edged sword, because it can possibly lead to a dependence. So if the patient see you as a highly skilled therapist, and then only with the skills, on the technique that you give, the patient condition gets better. Now, if the patient build it like that, then that's really a recipe for dependence. So, it can kind of, it can be a barrier for the recovery in the long run. Now, again, this I'm so special soul and a complex biomechanical theories used, I think these are the perfect weapons to facilitate dependence. And I've seen this quite a lot in a little bit older OMPT practitioners who probably hasn't changed the way they practice so much from like 20, 30 years ago. They haven't changed because it worked. It helped the patient. A lot of them use the very complex biomechanical languages and theories that really evidence has no support to. But from patients' point of view, it really doesn't matter because they really don't know. Many of them see the patient for like 6 months, a year. A patient keeps coming back because they truly believe that it's only that person who can do what they need to do. So really, it's these two things, I would say, is really a recipe for a dependence. And that's something that OMPT practitioners has been criticized for many, many years. So, it's almost to the end, and I kind of want to give this a quote from Dr. Lorimer Motley. He's actually the physiotherapist by training, but he becomes the international expert in pain research. So basically, he said pain isn't a biopsychosocial experience, and it requires a biopsychosocial approach to treat the pain problem. Okay, so I mean, this really quote sort of sums up what I wanted to present in this presentation. Basically, we need to find a way to use OMPT in a biopsychosocial way, if you will. Now, when the biopsychosocial model was first proposed by Dr. George Engel, I believe that was in 1977. Now, the core message was that the biopsychosocial model should lead to patient self-determination, which then leads to active coping. Now, the challenges from OMPT practitioner is that how do we use the modalities, which is by nature a passive modalities, to facilitate active coping? And that's really the challenges that we are facing as an OMPT practitioners now. And I do believe that pain neuroscience helps to bridge the gap that currently exists between OMPT practice and the biopsychosocial model. And that's why I think, pain neuroscience is an important science for OMPT. And as I said, in the last 4 or 5 years, I'm sort of I'm in a quest to master this, trying to fill the gap between sort of OMPT and self-determination, how I can facilitate it. It's difficult. I don't think I have found the perfect answers. Hopefully I sort of, I've given some food for thought for all of you. Many of you are into OMPT, want to use it. But maybe we need to sort of step away a little bit from the heavily biomechanical principle to really viewing the person as a whole. Okay, a person is a combination of biological process as well as psychological and a social being. And we can never forget that. Just because OMPT is only affecting the muscles, the joint, the bones, or fascia, if you will, it doesn't mean it doesn't have an effect on a psychological or even a social factors. Okay, so that's pretty much sums up my main point of this presentation. So thank you very much. And these are the references that I used. Okay.
Thank you so much, Dr. Hiroshi, for your wonderful presentation. We have some questions for you, if we may ask.
Yes.
Okay.
So I said earlier than I expected, but anyway.
Thank you so much for the scientific updates in the pain neuroscience, Dr. Hiroshi. Your lecture about the neuroscience approach has reinforced our beliefs in OMPT, which drives us to advocate more for the OMPT as a specialization in the academic and clinical settings as an association. Most of the OMPT techniques has not been discussed in the undergrad programs. That's why taking an additional course for OMPT is an advantage to promote better patient outcomes. Your insights on contextual factors to the outcomes is a good addition to our existing knowledge. I totally agree on the double-edged sword resulting to patients' dependence on the PTs. And the first question is related to your example in the biopsychosocial model in passive modalities. Some of us, Filipino PTs, are still utilizing the use of modalities such as electrical stimulation and ultrasound as our go-to pain intervention with gate control theory as their rationale for treatment. But with the updates in the pain concept you have discussed today, what are the strategies, tools, or techniques can you recommend to the participants to be updated in their practice to approach the patient's pain?
So that's a good question, because whether we talk about OMPT or modalities, I think, and I don't think many people may like this, but I think we're talking about pretty much the same thing, right? How analgesic effect is achieved, whether through electrical stimulation or OMPT, might be the same. For example, I talk about mechanism of OMPT, which is a mainly neurophysiologic effect, and probably has a lot of psychological effect in it too. So if the patient believes that electrical stimulation works, it very likely works. Whether it does what it's supposed to do, I actually don't even, I haven't used that for a long time, so I don't even remember how that mechanism of E-stem or ultrasound is now. But honestly, I think we're talking about the same thing, like how those modalities and OMPT works on the pain. It's probably the same. Now, what I like to emphasize here, though, you also need to think about why you want to use those modalities for. So whether it's E-stem, ultrasound, if you just solely focus on the pain relief, I think that's where the bad names comes, like even OMPT. So if you frame it in a way that you're using the E-stem to facilitate a movement or motions or exercises, and then maybe patient may need the modalities for now so that they can exercise or move. Again, you want to always follow up with some sort of a movement-based home exercise program after E-stem. So I think it's about messaging that comes as a modalities or even OMPT. It really, you have to have a messaging that is more sort of a motion-based. You don't want to just use the modalities, either ultrasound, E-stem, or even any type of OMPT technique just for the sake of pain. I think you really have to have, what's next. I don't know if that answered the question, but that's sort of my approach. My approach is never, whether I use OMPT or other things, I never just sort of stays on the pain reduction, because the pain reduction is just not the purpose from my point of view.
Thank you so much, Dr. Hiroshi. That explains well. My second question, or the second question from the participants is, fatigue is a precursor to pain, but it seems like from the definitions you provided, fatigue is part of the pain process already. The issue is that patients don't really come to PT unless pain is already bad. How do you simply explain the importance of early intervention to your patients to prevent acute or chronic pain?
So I did not present pain education in this presentation, but the pain education is one of the most recent sort of interventions that's based on modern pain theories, like I presented. And a pain education, it's got a lot to do with the what really pain is, neurobiology as a pain. It's really whole goal is to reduce the fear associated with the pain. We also probably need to combine that pain education with an OMPT as well. And if you use the OMPT in a more neuroscience ways, you should ease the fear or anxiety or uncertainty or catastrophizing belief that's associated with the pain. Now, as I said, if there's anything that I like you to remember from presentation, is the quote that I presented: "The fear of pain is worse than the pain itself." Okay, that's